Hello and good evening, everyone. Welcome to the International Dermatology Education Foundation webinar series. Today we have the pleasure of talking about the IL-31 neuroimmune pathway, the key to prurigo nodularis. I have the esteemed Dr. Daniel Butler, who is an assistant professor at the University of Arizona Department of Medicine and Banner University Medicine Dermatology Clinic. I am Dr. Ali Shabazz. I am a double board certified dermatologist, clinical assistant professor at Texas A&M School of Medicine, and a dermatologist at Westlake Dermatology in Austin, Texas. I'd like to take this opportunity to thank our supporter, Galderma, for this sponsoring this amazing educational webinar series. Before we begin, just some housekeeping rules. If we were having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the questions pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We greatly appreciate if you can fill out this very short but meaningful survey. In 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. For questions, please submit your questions using the question pane at the right-hand side of your screen. I will monitor and ask these questions to Dr. Butler at the end of the webinar. Again, I'd like to thank Dr. Leon Kircik, who is the president and lead of the International Dermatology Education Foundation, for inviting me to moderate this webinar, but also who has created this webinar and made this possible. The International Dermatology Education Foundation is a nonprofit organization whose principal mission is to raise awareness and improve dermatological care all over the world through education, especially in underserviced areas. And these are examples of previous esteemed guests that we've had the pleasure of inviting and learning from in past webinars. To stay up to date with any of the educational series, please follow us on Twitter, or formerly Twitter, Instagram, LinkedIn, and Facebook. And without further ado, I'd like to introduce Dr. Daniel Butler, who will be discussing the IL-31 neuroimmune pathway, the key to prurigo nodularis. Thank you. Dr. Butler, you are welcome to put your mic on, I believe, so we can hear. Apologies, I think we were just having some technical difficulties. Dr. Butler will be joining us momentarily.
Are we good to go? I am so sorry about that. At the most inopportune time possible, the power at my office turned off. But we are good to go if everything's good. I wasn't here for the intro, but I'm sure you did a phenomenal job. Are we ready?
Yes, we are. You're good to go. Thank you, Dr. Butler.
Awesome. Well, I am so sorry about that, but I'm glad it came back on when it did, because I'm excited to talk with everybody about this really new, exciting option for us in dermatology. And I think optionality is the best possible thing for us as providers in derm, and this is certainly going to give us an exciting new one. So today we're going to talk about IL-31 and the neuroimmune pathway as the key to PN, prurigo nodularis. And as I was introduced but didn't hear, my name's Daniel Butler. I'm here at the University of Arizona, and I direct an inflammatory and aging skin research program over here. So as we get into it, we'll talk a little bit about our new option, which is Nemluvio, nemolizumab, which is the first of its kind and the only neuroimmune treatment that targets the IL-31 receptor alpha. And it's really exciting to have this optionality. And let's get into it. Let's talk about prurigo nodularis. Disclosures, of course, here. So this is an educational program from Galderma Laboratories that's sponsored from Galderma Laboratories, and I'm a paid consultant for them. But all of the information here is consistent with the FDA required data. So no worries there. Let's get into the fun stuff. So if you take anything away from today, these 4 points are the topics that I want you to have. So we're going to talk about the patient experience, which many of us know, but I think there's still a lot of headway we can make in understanding the patient experience with prurigo nodularis. We can introduce Nemluvio to you and give you an idea of how to use it. We're going to get really specific about some of the efficacy and some of the effects this actually has on patients by looking at the Olympia clinical trial data. And then finally, we'll talk about the safety and the administration practices of Nemluvio so that you're ready to rock when patients come into your office with prurigo nodularis and you want to give them this option. So let's talk about itch in prurigo nodularis, 2 things that are intimately connected, and we've all seen it in clinic. So I think it's always helpful to start by just reading these quotes. They're things that you may or may not have heard in clinic, but things like, a lot of times I'm waking up scratching, or an itch that is just so excruciating, or alluding to the chronicity is, I've had PN for so long, I have scratched so much. You know, this goes back to our experience in clinic. And this is really a patient population that's been calling to us for a really long time, and I don't think we've really been able to answer it. And most of the time I say that's not our fault. You know, a lot of it is the frustration in treating these patients is that we really didn't have options. And what the core is of that struggle of these patients is really the itch. And that itch is something that's constant and unbearable, but specifically in this population, it's uniquely awful because it's a cycle and it just continues and continues and continues. And almost all patients with prurigo nodularis, despite the fact that they have these disfiguring morphologic nodules, papules, ulcers, they all say the worst part of their disease is that itch. So where does that come from? I'm sure you all have heard of or heard whispers of this neuroimmune mechanism. But essentially, when you look at itching is caused by 2 things, typically the immune system and the nervous system. And of course, that's an overgeneralization. I think each one of those statements is a career in and of itself. But those 2 players ultimately combine to create this symptom that drives prurigo nodularis. And this cycle is what continues to worsen the patient's state. So what happens is the immune system gets exaggerated, gets activated, has an aberrant response, and then that communicates over to the nerves. And that's why we like this analogy of the bridge, because the more immune activation and aberrant activity, the more that dysregulates the nerves. And then the nerves get dysregulated and they have aberrant activity, and then that communicates back to the immune system with more cytokines. And it's a cycle that continues and continues. And that pathophysiology is at the center of prurigo nodularis, that neuroimmune cascade that just continues to plague patients. And while that was exciting to discover, for a long time, you know, we were sort of treating these separately because we didn't have a way to combine our treatments. But now we're lucky because we have a cytokine blocker that can ultimately go after both of those entities. So the cytokine that I'm talking about here is IL-31. So IL-31 is secreted and then attaches to the IL-31 receptor, and that's a combination that ends up involving both the neuro and immune systems. And what we're going to learn a little bit more about is it's not just neuro and immune, it also combines some of the systems in our skin that are native to specifically the development of prurigo nodularis. But for simplicity's sake, let's think about it from a neuroimmune cascade. So IL-31 is produced by some of your regular players in the immune system. So Th2 cells, dendritic cells, basophils, eosinophils, macrophages, mast cells. And then you'll notice that they end up triggering these other cells that have IL-31 receptors, things like other immune cells, macrophages, basophils, eosinophils, but you'll also note other players that are native and unique to the development of prurigo nodularis. And when I say unique, I mean all bundled together. And that includes nerves, sensory nerves, and in the dorsal root ganglion, as well as keratinocytes and fibroblasts. So you're seeing that IL-31 has an effect on many of the cells that ultimately trigger our clinical presentation of prurigo nodularis, not just in the immune system and the nervous system, but beyond in the fibroblasts and keratinocytes. And so this IL-31 target or blocking target is going to give us a lot of generalizability in these different cell lines that have implications in this disease. So let's talk a little bit more about that. So when you block IL-31, you're blocking itch via really four different mechanisms, but really you're blocking itch in the inflammatory cascade by blocking its effect on immune cells. You're blocking itch via nerve suppression by blocking aberrant nerve activity. And then you're also blocking the dysregulation of our skin cells that we know ultimately can also contribute to this neuroimmune cascade by a disruption of the barrier, as well as aberrant fibroblast activity, which has a lot of different implications, but certainly can result in that nodular, firm morphology that we often see in prurigo nodularis. So if you look at IL-31 as a target, you're seeing that you're touching all these implicated pieces of prurigo nodularis, and it all is core to that itch. So this is something that comprehensively is covering the targets that we need in prurigo nodularis. I would argue targets that we really haven't been able to get in multiple different facets, all under one umbrella, and now we're going to have that. I love that about this medication because it doesn't leave us hanging just treating one thing. So without further ado, let's go right into what Nemluvio is and how it works and how effective it is. So Nemluvio, or nemolizumab, is our IL-31 receptor antagonist that's indicated for adults with prurigo nodularis, and its only contraindication is for those who've had hypersensitivity to nemolizumab or anything in it. So this is that same, I love this slide because it really hits on both pathophysiology and the targets of IL-31, but it hits all those different systems that we know are implicated in prurigo nodularis and are core to the itching and morphology that we see. Just to give you some really exciting mechanism displays of this, you can see that the blocking hits both inflammation and the nerves and gives us a block of that cytokine cycle cascade, and then of course gives us the opportunity to repair the barrier. And we'll show you some histologic features that are going to show you the repair of skin that ultimately happens at week 16 for those treated with this. And then of course the fibroblasts, which I think are like the under-discussed piece of prurigo nodularis, they're also affected by this medication. So what Nemluvio offers that we really don't have otherwise are these 5 things. So one is this unique mechanism of action. I feel like I've already beaten that into your brains, that the IL-31 receptor antagonism is something that is implicated across itch, but specifically in prurigo nodularis, it gives us a unique target that's going to be generalizable to the pathophysiologic mechanisms at play in prurigo nodularis. So number 2 is related to the efficacy, which is speed. So we don't have a lot of on-off switches in dermatology, and definitely not a lot of on-off switches that have a wonderful safety profile. And the fact that this works within 48 hours, which we'll talk a little bit more about, is pretty unbelievable for patients who have suffered for a really long time. So it works quickly. And then of course, even more important than an on-off switch is it durable? And the durability of this is fantastic. You'll see, and I'll show you from the clinical studies, the Olympia clinical trials, that this has durability beyond a year, which is unbelievable for these patients, again, who sometimes could get put on a quick burst of steroids and get some control, but that's not a long-term solution. And the data is looking like this is a long-term solution. And then, of course, as I've alluded to, all that is good and well unless all that is not good and well unless it's safe. And I'll talk about the safety profile of this, which is wonderful. There's no black box warning and there's no preliminary lab workup, which is so wonderful that that's becoming a new standard in dermatology, that we're not having to get someone to do labs and worry about their labs along the way before starting and while they're on the medication. And then the last thing is its ease of use. So this is a Q4 week or once monthly injection. And that's really lovely for patients, that if you're looking at someone who's well controlled on this or getting under control, you're looking at, max one injection a month for these patients, or at least one time a month that they're going to have to do the injection. And that's pretty special. So let's get into some of that. Let's talk about the study design and efficacies. But first, let's talk about the study design of the Olympia 1 and 2, which were the phase 3 studies, and then the long-term extension study that went out several years. So first and foremost, let's talk about the initial Olympia 1 and 2 phase 3 studies, where they had the inclusion criteria of course, being a person over 18 years old, with prurigo nodularis greater than 6 months. All patients who were included in the trial had to have a peak pruritus NRS score of greater than 7. For those who aren't familiar with peak pruritus NRS, basically greater than 7 peak pruritus NRS is crazy, crazy itchy patients. And I don't mean the patient's crazy, I mean the severity is insanely crazy, is insanely itchy. Of course, patients 5, 6, and 7 are still pretty itchy, but anyone over 7 I consider very itchy. If you look at equivalents like atopic dermatitis or chronic spontaneous urticaria, they're typically about in the 7s, whereas prurigo nodularis patients are usually about in the 8s, 9s for their peak pruritus NRS, and we'll talk about this specific population a little bit later. Patients did have to have over 20 nodules, which is common in other trials. And then their IGA score, their global assessment, had to be greater than 3. Exclusion criteria for these patients was that they had to have chronic pruritus resulting from another they could not have chronic pruritus resulting from another condition other than PN. Similarly to that, they could not have neuropathic or psychogenic pruritus, and they could not have active atopic dermatitis within the last 3 months. One thing I do want to point out is you'll see different endpoints for timing endpoints for Olympia 1 and Olympia 2. The standard endpoint was after 16 weeks, looking at the primary endpoint after 16 weeks, but based on a German recommendation from a patient advocacy group, they actually extended that out to 24 weeks in Olympia 1. So that's the difference between the two. But a lot of the reporting you'll see today will be at that 16-week primary endpoint. And of course, I should have mentioned this, but the power outage got me going off the start. Is any questions that people have, we can talk about at the end, because there's a lot of details as we go along. So at that 16-week mark, the two primary endpoints that were focused on were a reduction in the peak pruritus NRS of greater than 4 points. That's pretty standard for a reduction, a meaningful reduction in itch. And then the other primary endpoint at week 16 was a global assessment score, or a successful global assessment, which was defined as an IGA score of 0 or 1, which is a patient who is clear or almost clear, clear being 0, almost clear being 1, as well as a reduction of their IGA score of greater than 2 or greater, which was standard because any patient who is included in the trial had to start at a 3. So basically any patient who is at a 0, clear, or almost clear, 1. The secondary endpoints looked at different time frames, but a lot of the same things that we talked about with the primary endpoint. So a greater than 4-point reduction in peak pruritus NRS at week 4. They also looked at this the sleep NRS score at week 4 and week 16. That's the SD NRS, so we're focusing on sleep there. And then we're also looking at peak pruritus score less than 2 at week 4 and week 16. That's used as a proxy of an itchless state. So that's something you'll hear me refer to. So those are some of the secondary endpoints that we'll talk about here in just a minute. So let's talk about the patients who were in this, the largest trial for prurigo nodularis ever run. So if you look at the baseline patient populations for both Olympia 1 and Olympia 2, they're pretty balanced. You know, the interesting thing when these first came out was a little bit of an older demographic. That strikes me in my core because I love to talk about aging and its effect on our diseases. And I think, you know, 50 to 60 was an interesting age range. That's pretty true for all prurigo studies, and I'm so glad we're starting to understand this age range a little bit more. You're also seeing a really itchy population. You know, you're looking at a baseline itch score of about 8.5. So as I mentioned, that's a really, really itchy group, and that's balanced for both trials. And then interestingly enough, maybe not interesting, but pretty awful, is that over 30% of patients had over 100 nodules on their skin. That may not be a surprise for some of you who see prurigo nodularis frequently, but that's just covered. You know, that is someone who's really deformed by their disease. And that's true for both trials. But I like to highlight that because it just shows how truly high this disease burden is. Furthermore, diving a little bit into the baseline patient population, notable facts about the patient population in both studies is that you're seeing very similar and balanced pain scores. You know, a lot of people reporting daily pain. You're seeing a lot of people with really challenging quality of life measures before they were treated. You're seeing a lot of people with sleep disturbances. And then, of course, you're seeing a lot of people who've been treated with a variety of systemic medications. Obviously, we know that none of them are particularly gold standard, but again, mostly a balanced group, but daily pain, sleep disturbances, mental health challenges, and history of therapeutics were pretty similar across both groups. And then I think with talking about Olympia 1 and 2 and their endpoints at week 16, it's great to also introduce the long-term extension part of this, which was basically to take the patients who were in the initial studies and then allow them to be in this single-arm open label part of the study to extend out to 3.5 years, which is really the only, you know, this is essentially the state-of-the-art long-term extension trial for prurigo nodularis patients because no one else has done it this long. And we were able to look at an interim analysis at 52 weeks. So that would be the Olympia patients, so 16 weeks plus the 52 weeks to be able to get an idea of how responsive and how durable the response is for these patients, both who had been treated with nemolizumab during the trial, as well as those who were on placebo and then were placed in the open label extension. So it's pretty exciting that we have this more long-term data, and I'm going to present it to you because it's pretty compelling. Let me make sure I'm going in the right direction here. All right, perfect. So the baseline characteristics, again, you know, I don't mean to harp on this too much, but are very balanced, just like we saw with the Olympia 1 and 2 studies, you know, a very itchy population, very similar to what we saw previously with very, very dominant quality of life impairments in patients who had been tried on many different systemic conditions. So let's get into the fun stuff. Does it work? That's the question we're all asking. That's what we want to know. So if you're looking at Olympia 1 and 2, this is that 16-week primary endpoint. You're seeing pretty compelling data at that 16 weeks. So you're looking at 56% of patients and nearly 50% of patients achieving that greater than 4% or 4-point reduction in their PP-NRS score. So that's that meaningful reduction in itch. And you're also seeing IGA success. So this is clear or nearly clear patients. Now think of this. This is minimum 20 nodules many patients, over 100 nodules, you're looking at 25% of those with clear or almost clear in Olympia 1 and 38% in Olympia 2. That's really compelling, and it's almost a threefold difference between those who were treated with Nemo and those who weren't. So that is pretty wonderful to see for our patients, and this shows that this is going to be a really nice option to be able to use. I actually like this chart the most because I think it's hard sometimes to grade how prurigo nodularis patients are doing when they're getting treated, because there's so many different things that they worry about. Of course, itch is sort of first and foremost, but when do they start getting better? Is it when their lesions heal? Is it when their post-inflammatory pigment alteration gets better? You know, there's a lot of different pieces to this. And so it was important that we see some of this longer term data, because it may not be that you're going to get everything after 2 days, 4 weeks, 16 weeks. But if you look at the long-term extension and the interim analysis, so this is 52 weeks plus the 16 weeks after the Olympia study, you're looking at about 80% of patients, over 80% of patients who saw meaningful itch relief. So that's the greater than 4-point reduction in peak pruritus NRS at 68 weeks. And even more compelling is this is for the patients who got Nemo during their trial and then were able to continue it on the long-term extension. And if you see the gray line that's a little bit under there, you can see that once they were put on Nemluvio, you started to see that same response come back immediately. And that same durability of 8 out of 10 patients was still there for those initial placebo patients who then got put on drug after. So this is really, really wonderful. And I love seeing that climb initially and then that continued trend upward all the way over a year. That's pretty compelling stuff. So again, 80% of patients getting itch relief after over a year on this medication. So we talked about how durable the response is, but what about some of the cool interim data that we have? And I think that one thing I love about this, I talked a little bit about on-off switches, but this is a true on-off switch, and it was proven by the clinical data in Olympia 1 and 2. So you can see there that a statistically significant improvement of itch happened by day 2, 48 hours, and you can even start to see that split at day 1. So this is working very quickly. You're seeing that 48-hour significant itch reduction in a pretty strong subset of patients. And then even after a week, you're seeing 25% of patients that was replicated in both Olympia 1 and 2 having that dramatic response. So whether you're going to say that the on-off switch is 48 hours or 1 week, I think you can put the tag on this that it's pretty fast. And you're looking at about a 5 times better improvement than the placebo for patients on this, and it's going quickly. So that's at 1 week, and I love having that for patients, again, for this historical population who have been sort of much maligned because of how inept we were at treating it, and now we have something that could help them in 48 hours. I love to have that. This is one of the outcomes that I was talking about before, which was an itch-free state. And I love having this for patients because it gives them sort of the holy grail of where they ultimately want to be. Yes, the primary endpoints of a 4-point reduction in NRS is wonderful. And yes, IGA scores of clear, almost clear, are wonderful, but it's really the itch-free state that people are looking for. And again, if you shape the data this way and look for NRS scores less than 2, which is that itch-free state, you're seeing a really strong portion of patients, even in quick time, 4 weeks, 16 weeks, you're seeing a really strong amount of patients who are in that itch-free state. So you're seeing 20% of patients who are itch-free after 1 month, 4 weeks, and then you're seeing about 30% of patients who are itch-free at 16 weeks. That's 10 times greater than the placebo. So I think however you want to shave the data, it really does show that this is meaningful. And I think each one of these pearls from the trial can be something that you can tell a patient and explain a patient, what we're looking for in the result here. And these are meaningful results that you can share with the patient to say, hey, here's our goal. You may not get this specific thing, but here is a really strong portion of patients who are getting there on this medication. And then I love about itch because I think it's the best proxy for success, because a lot of the times with itching, it's hard for patients to really explain how bad the itching is. And I love asking about itch as a proxy for their disease. I can't tell you how many times I've talked with people and asked them how itchy they are, and they say, oh yeah, I'm pretty itchy. And I asked, do you wake up at night because you're so itchy? And they say, yeah, every night I barely sleep. To me, that's a really, really red flag that this person needs more aggressive treatment. And so when I get to see that there's great sleep data for a medication, I think that's really helpful because it gets to really the core of the patient's experience. So if you look at the sleep data here, very similar to the PP NRS, this is the sleep disturbance NRS, but you saw about 31 to 37% of patients had a greater than 4-point reduction in their sleep disturbances by 1 month. So again, very quick. And then you're looking at about half of patients with improved sleep, significant improved sleep by week 16. And that's really meaningful because when I talk to patients about sleep, I often will ask them if they're worried about a side effect of a medication or they're worried about going on a systemic medication. I'll use sleep as my argument because the detriment of not sleeping is much worse, of course, with an asterisk, is much worse than most side effects of many medications. And so to see this compelling data specifically targeted towards something that's so important, so critical, and can be so indolent and nefarious to patients if they're not getting it is really compelling when you're talking about convince somebody that they need to get on a treatment because this is something that can really help them. So I love seeing that half patients are improving in their sleep significantly at that 16-week mark. And then if you look at some of the clinical points, so we're looking at IGA success here, again, defined as clear or almost clear. You're again seeing and getting hammered with the success rates here. So at week 16, you're looking at somewhere between 26 and 37% success rates of clear or almost clear. That's pretty wonderful to see for these patients. And again, there's a lot of levels to getting clear. So the fact that you're seeing 1/3 of patients or 1/4 of patients getting clear in that speed of time is really compelling that clinically this is something that can help many patients. Another way of grading this clinical success, the visual morphologic success, is looking at the healed lesions. So this data point looks at the 75% healed rate. So this is the number of the number of people who get more than 75% of their lesions healed. I know I'm using a lot of numbers here, but I think this is really compelling data because it shows that 55%, somewhere between 40 and 55% of patients are getting healed, getting 75% of their lesions healed at that 16-week mark. And I think even more compelling than that, because as we know, that healing process can take a long time and has a lot of different benchmarks, from closure of the epidermis to restoration of the barrier to improvement of the post-inflammatory pigment alteration. The question is this a really durable response? So let's go over to the long-term extension, and you can see that this same data is present that we saw for the primary endpoints for the greater than 75% of lesions cured, or healed. So just to explain this very similarly to that primary endpoint is when they looked at the data in the long-term extension at the interim analysis 52 weeks, you're seeing that 80% of patients have greater than 75% of their lesions healed, which is just tremendous that there's that durability and that really strong percentage of patients. 80%, 8 out of 10 patients are having that sustained healing of most of their lesions, a heavy majority of their lesions. And again, that speaks to the efficacy immediately, as well as the long-term durability of this option. And of course, I'd be remiss not to mention that any patient who was on placebo initially and then got put on nemolizumab had that same result as long as they were able to sustain on the medication, which is really, really great for that exciting population. Of course, as dermatologists, we have to include the pathology, particularly when it looks so cool to restore the patient's skin like this. And anybody who's looked at histology is really familiar with the histology of prurigo nodularis and any prurigo nodule. But just to be able to see the restoration of that skin, you can see the profound effects that it's having on the keratinocytes and very likely on the fibroblasts that are driving those histologic changes, that hyperplasia, that regular hyperplasia that you're seeing. So I love showing that because I think it's just such a dramatic effect, and that's just in those 16 weeks. Not surprising because that's what you're seeing. That's what you're seeing from the clinical data as well. And then anyone who's talked to me knows that I love to talk about quality of life because I think sometimes we get lost in the morphology, and really we should be listening to patients more and more. And this is what really matters to patients, is the effect of their disease on quality of life. So when you slice the data looking at the quality of life effects, you're seeing that 75% of patients saw significant improvement in their quality of life scores. And then looking more specifically at that quality of life score, you're seeing about half of patients with a DLQI score of 0 or 1, which is essentially saying half patients are able to say that they are not having any impact of their disease because they're on this medication, which is really, really wonderful. You're also seeing meaningful reductions in anxiety and depression, which of course correlate very nicely with DLQI scores. And then you're also hearing from patients that they would rate this treatment as good to excellent, which is an important metric as well, is hearing what the patients think of the treatment themselves. And 70% of patients would call this treatment good to excellent, which is really cool to hear. So now that you've seen all the different ways that this has been measured with success in the clinical realm, the quality of life realm, you've even seen the histology, let's talk about the safety profile. Is it actually safe for patients, or is this just a quick fix? The nice thing is that this is really showing to be safe. In an Olympia 1 or 2, the main side effects that you're seeing greater than 1% of the time are pretty standard. So in the Olympia 1 or 2 trials, the most common side effect that they saw was just a headache. And then the other ones that they saw were atopic dermatitis, eczema, and nummular eczema. And the reason why they're delineated in different forms is that was actually up to the investigator, the PI at each site, to communicate. So that's why you're seeing the exacerbation of eczema. And of note of all these side effects is that the discontinuation rate was about 4% for nemolizumab and 3%, so not significant, for placebo. So that discontinuation rate was pretty similar for both nemolizumab and placebo. And then also of note is for those cases of AD and eczema and nummular dermatitis is that they were all mild cases. So a really favorable safety profile. And I know this is important given what else is out there on the market, but there was nothing in the line of arthralgia, conjunctivitis, or injection site reactions. And the safety profile is really, really compelling, given that it's not immune suppressive, there's no black box warning, and of course, setting that or continuing that standard of not having to do preliminary labs or ongoing labs is something that I know all my patients really, really appreciate. So let's talk a little bit about the details of being able to give this. I just gave my first patient Nemluvio today, which is really exciting. And it has a couple quirks that I think are really beneficial to our patients. So number one is that's Q4 week dosing. So it's once a month dosing. And there is a weight base to it. So every person, no matter what weight they are, will get 2 injections of 30 milligrams to start. And then those over 90 kilograms will continue with 2 injections every month, and all other patients will get 1 injection. So you can communicate to every patient that no matter their weight, they're going to be getting 1 dose a month as they go along. One thing that I love about this, owing to some clever engineering, is that this is actually available at room temperature for 90 days. And that's a huge benefit for patients, just given how crazy life is and how these medications are delivered. It's really nice that patients have that flexibility. And that's available because of this dual chamber system. So, you know, it makes it really nice that people can travel with this medication and they don't have to worry about all the refrigeration changes in most cases because of that 90-day room temperature storage. And I think that's a huge benefit and is really, really nice from a patient adherence standpoint. And of course, sometimes it's a pain to have to talk about access and ways to stay on therapy, but I'm glad that Galderma is staying ahead of that, and they're able to give support at every level when someone's going to either start this or think about starting this, and then for those who are on the medication who may need a bridge. So there are patient support mechanisms, office support mechanisms, provider support mechanisms for enrollment, at starting, and for helping patients stay on track. So if you need any information on those, there are plenty of resources to be able to tap into for patients who are starting or staying on the treatment if there's any challenges getting them access. All right, so to go over everything one more time is those 5 key points that we talked about. So we now have this option with a unique mechanism of action, blocking the effects of IL-31, which pervades all those physiologic, pathophysiologic systems of the immune system, the nervous system, keratinocytes, and fibroblasts that are all critical in the development of prurigo nodularis. This speed of this is really wonderful to have something that works at 48 hours, but also has that durable response out to a year. So not only is it fast, but we're seeing these same and actually improved results all the way out to over a year. The safety profile is pretty phenomenal for something that works that fast and has a durable response. To have something that doesn't have a black box warning and requires no labs is wonderful for our patients. And then of course, every 4 weeks is a very nice adherence option for patients. And if you look at adherence data, biologics are by far the most adherent medication, and the less they have to do it, the more adherent they are, not shockingly. So that's another wonderful piece for the patients. So unique mechanism of action, wonderful clinical efficacy at the beginning and during and throughout, well over a year, with wonderful safety profile and relative ease of use with Q4-week dosing. Here's the final safety information. And with that, I will be open for any questions. Thank you, and thanks for bearing with me as the power turned off right as I was getting started. So I'm sorry about that, but glad we got to speak today.
Thank you, Dr. Butler, for that fantastic talk. We're going to open the floor for some questions. You have a question pane on the bottom right-hand side of your screen. Feel free to type in any questions in that chat box. Dr. Butler, one of the questions that have come in is, what is the meaning of atopy background, or atypy background, excuse me, in the baseline characteristic of patients?
Yeah, so atypy background was defined as anybody with, what you think of as atopy. So that's asthma, rhinoconjunctivitis, eczema, and then specifically, when they're talking about people who've had active eczema, they're talking about people who are undergoing active treatment, or anyone who's had active asthma to the point of hospitalization within the last several months. So those would be the history of atopy that were included in the trial.
And speaking of the trial, why were topical calcineurin inhibitors and topical steroids prohibited from 2 weeks before baseline?
Yeah, I mean, I honestly, I think this is a really clever study, and it was just to make sure to see how effective this medication was as monotherapy. So that exclusion of 2 weeks before was, I consider it pretty brave to not have any of the sort of standard, which is, the topical steroid, but it really was to see its monotherapy effect. That's a brave thing for any itchy condition.
Absolutely. Another question just came in right now is there any indication of loss of effect over time?
No, I think that's one of the things that I would say, looking at the data and having combed through the data for the last, several months, is it really looks like it's augmenting over time. And that makes sense to me. I mean, if you'll let me go off a little bit, I mean, I think the neuroimmune mechanisms are a little bit more long-standing than some of the sort of traditional immune things that we block, like in psoriasis, that sort of shuts off. I think the increase in efficacy over time that you saw in that long-term extension data sort of speaks to the blockade of what it's like to block a nerve and to have the nerve calm down and then not have it continually sensitized by the immune system. So anyway, I'm sorry to nerd out there, but mostly I'm seeing what we saw there is, augmentation of the effect over time. You're seeing 50% efficacy rates in those early data points and up to 80 at that long-term extension interim data point of 68 weeks. So that's really exciting.
And it shows you the complexity of this disease and how hard it's been to treat it, right? The rapidity of the itch that needs to be treated, but also the chronicity of the immune mechanism that's already activated, right? And that's why it's such a chronic condition to treat. Another question that's come up, thank you for answering these questions, is what are the warnings and contraindications for prescribing nemolizumab? I believe you did go over that, but maybe just a refresher for some of our attendees.
Of course, yeah. So there's only one contraindication, and it's if you've ever had a hypersensitivity reaction to nemolizumab itself. Obviously, that'd be pretty rare. Or anything within nemolizumab, within the injection itself. That's the only true contraindication.
Wow, great. And with that, I think we will be ending our webinar series. Thank you again, Dr. Butler, for chairing this, and thank you, Galderma, for sponsoring this wonderful webinar series. We will conclude, and if you have any other questions, feel free to please contact IDEF, and we'll happy to answer those questions after the fact. Have a wonderful evening, everyone. Bye.
Thank you.